tumors are a little bit, I think, different than a lot of the other things that you will see commonly as a neurosurgery rotator, as a medical student, or even an intern. I think that's going to be much less common, things like trauma, infection, degenerative. Is that right? Tumors in general are going to be, what do you think, Dr. Rasouli?
Mets, you do see a lot of metastatic tumors to the spine, as well as infection. Those are probably the two most common things you're going to see in a major academic center. Trauma tends to be a little bit less common, just because it's more commonly seen in like a level 1 trauma center, and very frequently academic centers are not level 1 trauma centers. Some are, but not all of them are. And they often have a level 1 designation at a smaller hospital that they're affiliated with, as is the case where I trained in residency at Mount Sinai, as is the case here in the Cleveland Clinic. It's not a level 1 trauma center. We send our residents out to get training in different hospitals, which are level 1 trauma centers. So you see you see trauma over there. So to answer your question, metastatic tumors to the spine, you see it a lot. Yeah, you see it a good amount.
And so I'm glad you said that, because this talk, the way you learn them, whether you're a radiologist or studying neurosurgery school, whatever, you have to learn a lot of things that you're never going to see. So tumors that are parenchymal tumors of the spinal cord are extremely, extremely rare. I don't know how many of those you would see in your training. And then some of the other primary bone tumors of the spine are also very rare. So metastatic disease, yes, 80 to 95% of all spinal tumors is metastatic disease. And so this talk, what I did was, we're going to look at the more rare tumors first, just because those are the ones you need to learn. Metastatic disease is much more complicated. I think in terms of the imaging, it's going to be kind of always the same, but the workup takes a multidisciplinary team, and it's something you won't encounter, I think, as much as a resident or medical student. So we're going to do more of the basic spine tumor talk. And we can go through the first ones pretty quickly and see if we can get to metastatic disease, because that's the second half. And I agree, that's most common, it's most important, but it's a little bit more advanced as well. So let me do this. Okay, so the approach to tumor. So the presentation, these can present, in the ER. They can present in an outpatient clinic. Guy has back pain forever. He comes in to get imaged at some outpatient center. Or it can be a person that they know has cancer, but didn't know had metastatic disease. So they're going to their oncologist, they've got new symptoms, they're getting checked up, and they find that they do have, their disease has progressed and they have metastatic disease. So I think depending on where they are first seen, that will influence the initial workup. Treatment, though, that's where the end of the algorithm, those things will kind of converge, and they will be treated. There are a number of ways to treat them, but that's where all those people come together. But at the beginning, they can come from a variety of different sources. Now, like I said, the imaging approach is I think this is the way that you probably learned these as well, Jonathan. The way you identify a tumor, first you want to see in the spine, where is it? Is it in the osseous spine? Is it in the spinal cord? Is it in the dura, the meninges around the cord? Those things make a huge difference, can help tell you what it is. So you find out, so you localize it, where is it? What are your choices in that location? There are only a certain number of choices in any of those spots. And then based on other factors, you might be able to say exactly what it is, or at least narrow it down to one or two things. So, did I just go too far? This is a nice, ooh, that's bright. This is the most common spine tumors right here, this nice picture that I found. So you can see you have osseous spine tumors on this side. Primary bone tumors, extremely rare. Metastatic disease, 80 to 95%. So this is what everybody's going to see. You can see my arrow, right? Yes? Thank you. Okay. The other half of the spine, spinal cord, the nerves and the meninges. So you can have peripheral nerves, which we aren't going to talk about at all today, or you can have tumors within the canal, either intradural, intramedullary, which are parenchymal cord tumors, or in the dura, so in the thecal sac, but not in the cord parenchyma itself. And that's these tumors right here. Now, I'm not going to show you all these, but maybe try to show you some principles in the most common top ones there. So actually, do you want to talk about this anatomy picture, these different compartments? John, do you want to say anything about
Sure.
this beautiful picture?
So, just generally speaking, when you are discussing metastatic tumors, or just basically tumors themselves to the spine, there are different compartments that you want to look at. So it could be either, so you look at it in relation to the bone, the dura, and the cord itself, okay? So something can be extradural, which you can see there in the right portion of that image, extradural tumors. You see, like, it's right outside of the dura. It's either confined to the bone, outside of the canal or the foramen, or just outside of the dura. Then you have tumors that are intradural extramedullary, which means that they're inside the dura, but they're outside the spinal cord. Medullary refers to the spinal cord. And then you have intramedullary tumors, which are growing inside the substance of the tumor itself. So when you're discussing these tumors, or we're discussing spinal cord tumors, or spinal tumors, not spinal cord tumors, spinal tumors with your resident or your attending, you get a lot of brownie points if you mention this is a extradural tumor or intradural extramedullary or an intramedullary tumor. You can just, those are the three broad categorizations of the different types of tumors that can exist. And each one of them has different differential diagnoses and what they could potentially be. So it's good to kind of discuss that.
Don't mind my kitten making noise in the background. Sorry about that. Thank you for taking over while I was trying to take care of that. Yeah, so on the imaging, and we're going to use MRI as our imaging here, because sometimes CT, not x-rays. This graphic down here, I'm sure you knew this, but just in case, this is the spine right here. These are the vertebral bodies. So this is the thecal sac right here. The middle, the gray, is the spinal cord. This green thing is the tumor. So it's cerebrospinal fluid around the cord, and the red is the dura. So as you're just saying, so there's so many words here. I usually like to say parenchymal tumors, but yes, intradural, intramedullary. This will be in the cord, and it's going to expand the cord. Keep this in mind, because once you look at images, you'll understand what I'm saying. If you remember this, it'll help. So it expands the cord, and it narrows the CSF spaces around it. If those two things are happening, it's probably intramedullary, parenchymal cord tumor. If it's within the dura, but it's pushing the cord, so the cord is compressed, not expanded, that's going to be one of these two. So in this case, and I'll show you pictures where you can actually see this, it'll make more sense. Our dura is still here on the outside. The tumor is expanding this space, compressing the cord, versus this where the tumor is actually coming from the posterior elements here, like metastatic disease, epidural disease, pushing forward, compressing the cord, but you'll see this dural displacement as well. So with that, let me show you some cases, and all this will make a little bit more sense. Okay, so we're going to start with this category right here. So parenchymal tumors, intradural, intramedullary tumors. I'm going to give you, I think, 3 or 4 main ones. And actually, do you want to take this one, Rasouli, or should I explain the imaging and then you tell them what it is? You want to take the case? You can. Do you want me to go ahead?
All you.
You'll do it?
All you. I'll take a harder one.
Oh, all me. Okay. So this is actually a younger person. I think this is a 15-year-old. I can't remember exactly. Okay, so sagittal, this is a T2 weighted image. So spinal, and the only way you can tell that is down here. Spinal cord is gray, CSF is bright. So you can see this whole cord, this is just a huge mess. It's expanded, the cord is expanded, the CSF spaces around it, as you see here, are gone. So we know it's a parenchymal intradural intramedullary tumor. So on a T2, we can see that there's some soft tissue to it. This is the tumor. There are also cysts involved, so they're bright, they're water, they're like the color of CSF. Huge, expansive tumor, not well defined. The margins, if you said draw exactly where this thing is going, hard to tell. Down here, maybe here, I'm not sure where the margins are exactly. This picture is a post-contrast sagittal. So the tumor itself, the soft tissue of the tumor is enhancing. Very, very ill-defined, kind of all over the place, infiltrating tumor. Big cyst above it. This is normal spinal cord kind of up here. Kind of not really normal down here. So a long segment tumor, cystic and solid, enhancing, young patient. I'll go on. So those are your choices for intramedullary tumors, the main ones. you want to say anything about that?
No, I think it's very.
Okay.
Yeah.
All right. Should I go on? Okay, so that's going to be an astrocytoma. So your two big choices, I think, when you see big parenchymal tumors in the spine are going to be astrocytoma or ependymoma. Almost always. There are a couple others, but those are the main ones. You want to differentiate for boards, for tests, for pictures you'll see wherever. So 30 to 40%, a little bit younger patient infiltrating, so you don't know exactly where the margins of these things are. And that affects the treatment options, which I'll let Dr. Rasouli talk about. Usually a very long segment, third or half have some kind of cystic component or syrinx associated with them. Syrinx is dilation of the CSF space, is not a true encapsulated cyst. And some of these will have metastases in the rest of the spine, so you might want to get other imaging, like in this case, the lumbar spine or the brain. I'm going to go on to the next. I was going to go through these cases quickly. If you want to say anything about it, let me know, or I'll keep going.
I would just keep going. Yeah.
Okay. So next one. Like I said, this would be fun to describe these more, but I want to get to the mets. So I'm going to go through this part kind of quickly. This one, lower in the spine, maybe in the conus, more well-defined, so sagittal post-contrast, enhancing, essentially non-enhancing. We know it's intramedullary parenchymal because it's expanding the cord, the CSF spaces around it are gone. And that's an ependymoma. So those two are the most common that you'll see. Those are a little bit older patients, not always, but 60-70% are ependymomas. There's a little bit more common. Ependymomas come from the ependymal cells that line the central canal of the spinal cord. So your spinal parenchyma is all soft tissue except in the middle where you've got a hole where the CSF goes. And I'm simple, so I'm explaining this simply. I'm sure Dr. Rasouli could say this much more scientifically than me. But there's a hole in the middle lined by ependymal cells. It's kind of like your ventricles in your brain. And that's the origin of ependymomas. And so they will almost always have some connection to kind of the center of the cord itself. They won't be eccentric or peripheral. You'll be able to see that it kind of came from the middle and it expanded outward. They're not totally well circumscribed, but better. And most have cysts, and these can often hemorrhage. I don't have a picture here, but if you see black on these pictures, that's how you see hemorrhage on spine MRI. And it's hemorrhage, that's likely to be ependymoma, although not always. Astrocytoma can do that too. I'm gonna keep going until you jump in there, Rasouli. Okay, this one, here's a cervical spine. So sagittal T2, sagittal post-contrast. This one you can see there's a couple in this person, a couple enhancing masses. A lot of these little black dots behind the spinal cord are prominent vessels, mostly veins. And then you see there's abnormal T2 signal within the cord. So this is not always a entirely intraparenchymal tumor, but most of them are. And this is a angioblastoma. Here you can see it's not in the center like an ependymoma. It's kind of, this is my only axial image I have this. It's kind of out on either the outside or on the surface, half in, half out. So these are rare, actually, very rare. 60% are entirely intramedullary. Others, 40% are intradural extramedullary. So those are, kind of fits in this category. About half of them you'll see in the thoracic spine. These also often have cysts and a syrinx, abnormal collection of CSF in the center of the cord, and these phloboids, because they're very vascular. And 80% of these will be just solitary tumors, but people with von Hippel-Lindau, which is the most common way I see them, we do surveillance on these people with von Hippel-Lindau disease. And so we watch these, and they get surveillance like every 6 months or a year, and we see if these spinal hemangioblastomas have grown. Anything else before I go?
One thing I want to say about this is if you see a discrete lesion like this, you see these hemangioblastomas, they're kind of discrete, they're well circumscribed and almost homogeneously enhancing in some way. If you see it's a tiny lesion, but you see tons of edema, or a tiny lesion and a huge cyst, that's often a hemangioblastoma. The cyst and the edema are way out of proportion to the size of the lesion. That's usually a good rule of thumb.
That's good, and that's what this this first picture is showing. There is quite a bit of edema or syrinx that's going along with this. Yeah.
And those phloboids, those veins, are usually more associated with AVMs. They can be associated with hemangioblastomas, but when if you just looked at that left T2 image, my initial thought that was an AVM.
Yeah,
See that
although if you saw it if you saw a different slice in the axils, you'd see there was a mass there, and then you would know it wasn't an AVM. But yeah, they are very vast. This is an extreme example. You typically won't see this, but this is just to show that there are clovoids often there because they are so vascular. So, all right. And then metastatic disease can be parenchymal, although here I'm showing you drop mets, which are along the Cauda Equina. In this case, you already know this person has cancer. This isn't going to be like a new diagnosis with this picture. Person might have, tumor in their brain, elsewhere in the spine. But I had to put that in this category. So this is sagittal post. You can see they have osseous metastatic disease, abnormal enhancement in the vertebral bodies here, as well as these little enhancing masses along the Cauda Equina. And this is a sagittal T2. Again, you can just barely see these little masses with the nerve roots right here. Okay, so second compartment. So intradural, but not in the parenchymal, the soft tissue of the cord. So intradural extramedullary. Couple of those. I want Rasouli to take some of these cases. I don't want to have to do all the talking here. But sagittal T1 post-contrast with VATSAT, sagittal T2. So this one, it's a little bit hard, but if you imagine this thing was on this side, we have a tumor here that's compressing the cord. So it's not expanding the cord, it's pushing the cord away. And we don't see any kind of dura being tented up like it's coming from the bone, like an epidural process. So that's this picture right here. So these are your choices for intradural extramedullary tumors, the main ones. So meningioma, schwannoma, some kind of a spinal cyst, or again, metastatic disease, which can be in any compartment. Oops, I went too far. So I didn't explain it. That one was a meningioma. This one is a schwannoma. So same thing, see how it's pushing the cord away. It's not expanding the cord, it's compressing the cord. But the dura, there's no tenting of the dura, so we know it's intradural. This is T2 hyperintense. It's a little bit heterogeneous. On this axial post-contrast, it's enhancing. And what we know about schwannomas, they're very slow growing and benign. So it has expanded the neural foramen on this side. So the nerve roots come out on each side. Here's the cord. They attach to the nerve roots. Expanded neural foramen. We know this has been there forever. Aggressive tumors don't do that. So that's a schwannoma.
Wendy, I would add neurofibroma and MPNST in that differential diagnosis.
So yeah, I didn't want to get too complicated. So I should have said yes, nerve sheath tumor. And yeah, the malignant peripheral nerve sheath tumors are a whole nother category. We won't get into that today. But typically these are older patients. Again, we know it's slow growing. This is a CAT scan. This is an axial. This is the spinal canal in the middle. This, you can't really tell, but this is right above the foramen. You see this very sclerotic line around this. It's grown forever, years and years and years. This tumor has been growing and remodeling rather than destroying the bone. So this is a benign tumor. And this is how you know this is going to be a schwannoma or a neurofibroma. And I actually thought of a question for you. I've asked it before, but I'm going to ask it again. At what point would you do surgery on a patient like this?
If they're becoming symptomatic or it shows progressive growth.
Because they do grow. So if they've been growing over years, like a millimeter each year, you wait till they're symptomatic.
It's bothering the patient, as in if they're becoming symptomatic as a result of that, if they're having like horrible radiculopathy or pain, then you should operate on it. Or if if something that was if it's starting to grow and starting to compress on certain structures, or starting to, as you can see, it's developing bony erosion here. Those are indications to operate.
So I agree with you. Now that isn't the answer I've gotten every time, so I'm glad you said that. Some people will do surgery on these before they get symptomatic, and they're often not symptomatic because they've been growing forever. And so it's actually a very hard decision, I think, for the surgeons to make when to intervene, because like you said, sometimes it's going to, it's going to compress something, you just don't know when. And you want the surgery to be done when it's easier rather than harder. But you don't want to do it if you don't have to. So that's maybe a topic for another time. But I think it's complicated.
you're right. If the lesion is small and the patient's asymptomatic, I don't see any role for surgery.
Yeah, agreed. But
Even
if it's big and it's asymptomatic,
yeah, no, I would say like if that's the logic, then when do you not operate on them, right?
exactly. That's what I asked. I agree with you.
Right.
That's
So
what I asked you.
yeah.
Okay, that's a whole nother discussion. See, we should do that on virtual spine someday. All right. Okay, here's another one. So look at the picture up here. It's pushing the cord, compressing the cord, but the dura is not pushed in. So intradural, extramedullary. It's a different color than the spinal cord. CSF is white, cord is gray. This thing is pushing on it. This is a T2. This is a post-contrast. It's enhancing. This is actually, this is kind of complicated. It's a fat-saturated post-contrast. So this is regular post-contrast. And this is, so the subcutaneous fat is bright. This is fat sat. So that means this thing is fat. That's kind of complicated, but that's the key here. So this is actually intradural lipoma.
Lipoma, yeah.
Never mind, yeah.
Well,
I've never seen, this is the only case of this I've ever seen. I don't know how, these are super rare, I think.
Yeah, these are very rare. Unless you're dealing with spinal dysraphism in infants. We have like, lipomyelomeningocele and sacral lipomas, that kind of stuff. That's where it's far more common, but very rare in adults.
Okay. And then, special category. Cauda Equina is a little bit different. So the most common things you'll see there: myxopapillary ependymoma, schwannoma, or neurofibroma. Again, nerve sheath tumors. So I have a picture of multiple nodules. You know what this is going to be recently? John, you know? Anyway.
There's multiple neurofibromas, or is that like?
That's close. Yeah. So that is perfect. Usually you would say neurofibromas. In this case, it's actually multiple schwannomas. So it's schwannomatosis.
Is it NF2?
No, it's schwannomatosis, which is the new category. That designation is relatively new. So it's not NF1, NF2, it's schwannomatosis, which is the third one.
Interesting.
They have no neurofibromas, they have no intracranial tumors, only spine. So, or nerve, not spine and nerve. So this is interesting because these things are benign tumors, schwannomas, super benign tumors, and yet they can devastate a person. And this person has had, the only treatment you can really get is surgery. There's no chemotherapy, nothing else you can do to treat these. So when they get large, as we were talking about, and symptomatic, you have to take them out. But otherwise, this person just kind of has to keep getting surveilled. They keep growing. They keep getting surgery. So benign tumors, but a terrible disease. And that's something, again, the medical students here will know a lot about. You're studying this in your different courses, so you've probably read about that. All right. So now we're going to go to the other side of the little chart. So remember, this was osseous primary tumors or osseous metastatic disease. And that's kind of where this extradural fits in. So this is, I'm just going to tell you, this was metastatic leiomyosarcoma, I believe. But you can see how beautiful this picture is, looking just like this figure. I love that just for that reason. So the cord is being compressed. It's not expanded. It's not parenchymal. It isn't within the dura. In that case, the dura would be coming straight down behind it. So it's not that intradural extramedullary. In this case, it is truly extradural, and this is the dura, this black line coming down behind. So CSF, spinal cord, CSF, dura, and it's being pushed forward by this tumor, which is extending from the posterior elements of the spine, the osseous components of the spine, and it's kind of epidural extension, basically cord compression from an extradural mass. So it's compressing the cord there. So extradural osseous mets, 80 to 95% of everything you're going to see. But we also, just for the sake of categorization, put multiple myeloma and primary bone tumors in that. So this is multiple myeloma. I'm not going to go into that because it's not a surgical disease, so we'll skip over that. Primary bone tumors. This is a plasmacytoma. So 5, 4, 3, 2, 1. This vertebral body is abnormal. You see these black things in it. Black cortex, draw a black line. Black things in the middle mean that's also a different type of bone. So this mass has been growing forever because the mass is replacing normal bone marrow. The struts that hold up a vertebral body, the trabecula, have to get bigger to support the vertebral body's, the pressure on it from above for gravity. So the trabeculae get expanded, and that's what causes this very unique appearance of a plasmacytoma. This is an axial.
Wendy, can you comment on the disc space involvement with tumor versus infection? This is a nice picture here.
So disc space?
Yeah.
Disc. So the only tumor which will cross a disc space is a chordoma. There are no other tumors which will involve disc. So if you've got disc involvement, unless it's chordoma, it's not a tumor.
Exactly.
Like that? How's that?
For the next, if you see the discs very well preserved, it often means that's and you're wondering infection versus cancer. It's usually cancer. Cancer usually preserves the disc spaces versus tumor, which is infection, which will involve the discs.
Nice, unless it's chordoma, which I see all the time, but nobody else will ever see. So okay. Oh, did I go too far? Oh, I just put this in because this is another plasmacytoma. So plasmacytoma, if you've studied this yet, you know that oftentimes if it's a solitary tumor of plasma cell disorder, it's plasmacytoma. If it's multiple, then it's myeloma. So they're very similar. In this case, though, these past two cases, this was the only tumor in the body. So those are considered primary tumors and treated as solitary tumors for unblocked resection. Or if they're treated that way, sorry, if they're treated surgically. So this one's L4. This one has collapse. The posterior cortex is going back into the canal. It's compressing the Cauda Equina, giving this person symptoms. This is really old picture, but this is a post-contrast. You can see it's all enhancing. The bone is expanded more than destroyed. A lot of tumors that are very aggressive, fast-growing, like renal cell carcinoma, will destroy the bone. And very few tumors actually expand it, but the primary bone tumors are more often expansile. This is a CT, and again, you can see that trabecular thickening. It's not like primitive, like it's being eaten, whether it's by infection or tumor. It's more like it's being very slowly remodeled, and this trabeculae are getting bigger as the soft tissue of the tumor replaces the normal marrow. And here's another CT. All right, so those are the main bone tumors. And again, I just want to go through this part quickly because these are the ones, I mean, you'll see them, but again, not anything like metastatic disease. This one is with this is an axial. It's kind of hard not seeing all the images, but I didn't want to spend too much time on them. This is an axial T2. And you'll see all these little locules with different, bright on the top, dark on the bottom. And these are hemorrhage levels. So there's blood and fluid in these. So a bunch of fluid levels. This is an aneurysmal bone cyst. Maybe, can you talk about that, Jonathan, a little bit about those? Just because they're kind of cool. That's probably the coolest of all these, except for
these are a little bit weird. Aneurysmal bone cysts, or ABCs. They are very hemorrhagic primary tumors of the bone. This is a great picture, by the way. I like this MRI a lot. I'm kind of I just keep staring at it. But if you CAT scans are also interesting as well too. They have this kind of soap bubble appearance, or it's very characteristic appearance on CAT scan. These guys have actually, my first experience with aneurysmal bone cysts is one that actually ruptured in a young patient and caused an epidural hematoma in the mid-thoracic spine. The patient needed emergent surgery. So these things are not they're technically benign, as in they don't metastasize to other parts of the spine, but they can behave very, very badly. So these are, they're if and when possible to remove these safely in a patient who has one. They're generally good to take out if possible, but there is room for surveillance on these things. You can watch them if they're small and asymptomatic. They were found incidentally. You can watch these.
Yeah, and that's the issue, is that these, I mean, there's basically no normal bone there. And so I wish I had a sagittal on this one, but there's nothing, and you can imagine it's like an eggshell. That thing could crack at any time. So they are problematic, and you do have to probably, when you do your surgery, you have to probably replace it with something, right? We'd have to put something in that defect to keep your spine normal height, maybe. Anyway, that's for another time too, probably. All right, next one is, this is a chordoma. Again, this is the only tumor that would cross a disc space. Chordomas are a little bit unusual. So sagittal T1, it's dark. This is, I guess, sagittal T2. Maybe, I'm not sure what that is actually. Maybe that's just showing a different angle. This is a different kind of T2, which is taking out all the fluid. This is a fat-saturated T2, very bright. So chordomas are very, very bright on T2. They may not enhance avidly. So that's how you know, again, this is something you'll learn later when you do your radiology rotation. These can be at the skull base. They can be cervical, thoracic, lumbar, spine, notochordal remnants. I love chordomas because they're fascinating. They're horrible tumors because, as you can see, like this is replacing the entire sacrum. This person's got to get a sacrectomy, and you know all the nerves that are coming out of the levels, you know, the sacral levels, and those are important nerves that have important effects. They control important functions, and maybe Jonathan, you can talk about that. But these are things we biopsy all the time. You want to, when we biopsy these, we have to mark the track where we went because they can seed and have tumor deposits grow along the track of your needle. Surgeons usually, not always these days, but usually do an en bloc resection followed by some kind of a radiation, proton, or gamma knife therapy at the bed. Do you want to say anything about these?
These are the mother of all tumors. These are the most difficult surgically to take out with the highest stakes. These are tumors that should be handled at a center that is experienced with taking these things out. It should not be done in a place that does one a year. These should be done at a cancer center that has all the multidisciplinary and all the physicians and surgeons are able to and experienced to take these tumors out, because there's so much that can go wrong, and to really to achieve long-term remission and control is extremely difficult. These are the cases that you read about or you see like in the news where it's like a multi-day or one of these like 30-hour surgeries with 15 different teams, front, back, front. These are very, very challenging cases.
Yeah, and when you have your breakout sessions after we're done, maybe John Shin will show a case of this. I hope so, because he does these tumors.
Yes.
For sure, and he's doing the tumor section, so hopefully he'll show a case.
Yes. All
right, chondrosarcoma, just quickly, heterogeneous enhancement in this last picture, which is the post-contrast fat-sat. Pretty much all tumors, they kind of look similar. So they should be T2 somewhat bright, T1 hypointense. This one, it doesn't enhance avidly because it's got all the, it's got other cartilaginous components and other components in it. But just because it's not avidly enhancing doesn't mean it's not a tumor and a bad one. This is a cool one. I wish I could show you more, but maybe some other day. This one, okay, so osteoid osteoma, or if it gets to a certain size, osteoblastoma. Young patient, pain at night, has this sclerotic focus right here at the kind of the intersection of the lamina and the pedicle. And here you can see it on the sagittal right here. On MRI, he's got edema around it. It's this black focus right here, black focus right here. So I don't think surgeons always treat these. We can treat these actually with radiofrequency ablation. So I would go in there and put the frequency probe in and burn it and actually kill that tumor, and that can relieve the pain. Or, if it's an osteoblastoma, or maybe surgeons would just go ahead and treat it as well if it wasn't amenable to a percutaneous approach from radiology. Yeah. Okay. Yep. This one is
one of the things, if they ask you a question about that, is responsiveness to I forget if it's aspirin or NSAID.
Yeah, that's the board question, right? I think it's you take NSAIDs for it.
Yeah.
Yeah.
So either aspirin or NSAIDs. I don't remember.
I'm sure somebody in the chat can tell us the answer to that. They'll know. They'll remember.
That's the buzzword there.
That's the first question. Yeah. Okay, so lymphoma. So this is a little bit different category. Not quite primary bone, but it is primary bone in a way. So here's our sagittal images, post contrast in the middle. You can see this big enhancing collection back here. This is the spinal cord, big enhancing collection behind the spinal cord. If you saw this and didn't have any history, you might say, okay, is it an infection? Is it a huge epidural abscess? Is a big epidural hemorrhage? And it's actually soft tissue, and this is a patient with known lymphoma, and you would usually know the person has lymphoma. Down here on this axil at the bottom, you can see lymphoma kind of coming out of the bone, but it's circumferentially engulfing kind of the thecal sac in the epidural space and compressing the thecal sac, even though there's not cord compression. Let's see what else we got here. Oh, this is another case. So this was super subtle. So we were doing, so I do a lot of intrathecal chemotherapy. And where I was before, they didn't ever get MRIs because there was no MRI in the cancer hospital. I shouldn't say that, but there wasn't, and there isn't. So we would just do lumbar punctures for putting in chemotherapy for patients with leukemia and lymphoma. And there was this one patient, and we do them, some people get it 3 times a week. Some people get it once a week. Some people get it once every month, whatever. This guy kept getting harder and harder. We put in the needle. At first there's a lot of cerebrospinal fluid coming out. Next time, not as much. Next time, not as much. And it started hurting him more and more too. And it wasn't the technique, of course. The lumbar puncture itself was perfect. But we finally said, something's going on here. We're not getting CSF. You please bring the patient over to the other hospital to get an MRI. You can actually see it on this myelogram, but in retrospect, actually you probably see it prospectively or looking for it. But there's some little, this is a contrast MRI. There's dense stuff. Actually, this is non-contrast, sorry. There's stuff around here which is dense, which that corresponds with this soft tissue around the thecal sac. So cerebrospinal fluid is bright, is the white stuff. Little nerve roots of the Cauda Equina in the middle. This black line, this is thecal sac, and all this soft tissue is lymphoma compressed in the thecal sac. So you can see why when we tried to do our lumbar puncture, we weren't getting any fluid out because there's none left because it's being compressed. And this is the sagittal MR for that poor guy. And he has both osseous disease as well as extradural disease in the canal itself, compressing the cord. Now, metastatic disease, by far the most common thing. We'll see, how much time do we have? Jonathan Rasouli, 15 minutes?
I think so, yeah. We're 12:15 my time here.
Okay. So, sagittal CAT scan. Axial CAT scan. This was a body image, actually. This wasn't one for me. It was an abdomen scan. You can see in the spine, look how much whiter this is, and this, and this. Sclerotic metastases in a patient with prostate cancer. So there are multiple here in 4, 3, up here in the T-spine. So these are the different modalities that you're going to see and you might order as medical students when you're evaluating patients with mets. This first thing is a bone scan, and people still get bone scans, and maybe they usually look better than this. But there's a little bit of uptake of radio tracer in the biggest met, which was here in L4. We do these front and back, and they get an initial image, and then they get a little bit of a delayed image with more radio tracer uptake. This is a fast, cheap, easy way to see how widespread the metastatic disease is, because you see the whole body. I can see if they have a met in their arm. I can see if they have a met in their skull, in their foot, whatever. So not the best anatomic imaging, but great for picking up certain kinds of mets of the whole body, like I said, very fast. And then you can get more advanced imaging later. Now this is a PET scan. So on the right, this is the typical PET scan you would see with the color, but this is the black and white version. And it looks like, I made this picture because it looks almost exactly like a bone scan, except see how well you can see every metastasis here. It's like a bone scan, better. But PET, of course, is a lot more expensive and it's a lot harder to get. These days, I mean, it's not terribly hard in an academic center, but it's not the fast, cheap 10-cent exam like the bone scan is. But if you can get this, that's great. And then, of course, we like them colorized, and the tumor shows up a different color. So FDG, avid, metastases here. I just show you one slice, but there are multiple, and they're yellow because they're hot. They've got a lot of FDG avidity with that prostate cancer. All right, so these are the typical MR findings of a metastasis. This picture, so I told you the different ways that a cancer patient can present. This one came into the ER. So again, county hospital, no medical care. So they came in, no history. They didn't want to tell us anything. You know, some people come in and they don't want to tell you, they don't really trust the medical system, but they have to come in because they're in terrible pain or they've got deficits. That's what this lady said. I have back pain. She wouldn't tell us anything else. But it doesn't matter because in this case, we already know what this is going to be. There's only one possible thing that could have this MR appearance, and that's metastatic disease. So that's sagittal T1. Normal bone marrow is white because it's got fat in it. This one is not white. This one's dark because it's completely infiltrated with tumor. It's also got a pathologic fracture, and it's compressed posterior cortex bowing out into the canal, compressing the thecal sac and the Cauda Equina. Down here, there's another little one here in L3 and one in L4. Sagittal T2 shows the cerebrospinal fluid, can show you how much better than the T1, how much thecal sac narrowing there is. So you can see again, this is a little bit off from this one, but retropulsion of the posterior cortex into the canal, compressing the conus. This one, I told you there's a different kind of T2. This one is a fat saturated T2, takes out all this whiteness from the vertebral marrow. So it's only highlighting edema, tumor, or infection. So all this brightness in this vertebral body is edema and tumor. And it shows these two as well. Sagittal post-contrast, and again, fat saturated. They don't do that where Dr. Rasouli is, but they do it where I am because it makes it easier for simple radiologists like me. Highlights all the areas of tumor. So amazingly, I thought this whole body would be enhancing. It's not, only the posterior, as well as the epidural enhancement, so epidural extension of disease here at L1, and then enhancing METs at L3 and L4. And here are axial images at the level of greatest compression. This is the T2 showing the thecal sac. Everything here is cerebrospinal fluid, not much left because it's being compressed. And here's our post-contrast fat set. This looks almost exactly like our infection case from our other lecture, doesn't it? It looks just like that from our first case. So it's got enhancement around the vertebral body, enhancement in the epidural space. But in this case, it's not infection. It's actually tumor with epidural extension of disease compressing the cord. So we're never going to get through all this, but maybe, Jonathan, do you want to talk a little bit about the treatment, or do you want me to kind of go through these slides? How would you best like to approach this in a half-hour talk in 10 minutes here?
There's a lot of, it's very nuanced. So it really is, there are a lot of different protocols that exist in terms of what treatment should be done, whether it's more, chemoradiation versus maximal surgery versus, in some instances, hospice PAL care. And the things to keep in mind are the patient's Karnofsky performance score. Those are very, very important things. Patient preferences. How aggressive are you going to be with a patient who, say, is 85 years old with widespread metastatic disease, numerous medical comorbidities, and versus someone who's like 30-something years old, who's healthy and has, say, some metastatic tumor in their spine. There are a lot of different things that go along in this, or it's not a cookbook type of decision making. The two papers I would recommend for the medical students to read, which definitely helps break things down and help guide your decision making, are looking at the NOMS or NOMS criteria, and I'll post a little link to that in the chat box, and the SINS score, or this spinal instability and neoplasm score. So it kind of helps guide your decision making in certain ways to make things a little bit more simpler, because this generally tends to be very, very complicated. There's so many different branch points and forks in the road when it comes to the decision making tree. But for the medical students, at least, those are the two things you guys should know: NOMS and SINS. And I'll post links to that on the.
I'll show you pictures if we get to it in the next 10 minutes. We'll show pictures of that too. So thanks, that was good. So the treatment of metastatic disease has really changed recently, and those of you in medical students and even residents now, this is going to be what you think is always been. It's going to be the standard of treatment. But I think for those who are practicing spine surgeons who've been around a little bit, and I see our other hosts have joined us here, this for them is maybe somewhat new. Maybe when they started practicing, this wasn't the way things were done. And it's still, I think, maybe being adopted. But like Dr. Rasouli just said, the NOMS and the SINS score help us evaluate these cases. But stereotactic radiosurgery and SBRT are relatively new, as well as new surgical techniques, which help us treat tumors, which are metastatic disease. Tumors which are metastatic, which previously were not amenable to treatment. So it was kind of a death sentence before. Now it's kind of, in some rare cases, meds can be almost a chronic disease to be managed. And some of those patients can live quite a long time. And so many considerations are different now. So this is a renal cell carcinoma. I just like this dramatic picture. Here you can see an axial CAT scan, huge renal cell. I'm amazed that this guy let it get this bad, but in some places, again, people don't want to come in for medical treatment until things get very bad. This is a different metastasis from renal cell, the sagittal post-contrast. and then this is the surgical result. So you have a number of different treatment options: surgery, radiation, chemotherapy, immunotherapy, hormonal therapy. I might even be leaving something out there, I'm not sure. Like Dr. Rasouli said, there are a number of different frameworks. I'm going to see if I can get to, this is the NOMS, the primary components of NOMS, and I'll show you actually the little graph in a minute. But that considers your neurologic status, which is cord or nerve root compression; oncologic, which is the histology of the primary tumor and its radiosensitivity to conventional external beam radiation; your mechanical stability, because if your spine is unstable, that's almost more important than your metastatic disease, and that you have to get your spine treated, stabilized, before you might get your further treatments for the cancer itself. Because if your spine fails and you compress your cord, severe pain, paralysis, death can happen before anything with the cancer that might do to you. And systemic statuses. As Jonathan said, life expectancy, other comorbidities. And these were some of the tumors. This actually is a very old slide. Some of them that were very radiosensitive versus not. And a lot of the ones that were not very radiosensitive, so couldn't really be treated with radiation, now are amenable to stereotactic radiosurgery, or in the spine, stereotactic body radiotherapy is the proper term. These survivals, I think this is even outdated. I need to update this because a lot of, like, especially melanoma, now with the new immune treatments, that is actually, I think, much longer. And I'm sure Dr. Shin will talk about that. So this is the NOMS framework that Dr. Rasouli just mentioned. It's very complicated. Like I said, we won't go through it now, but these are the different considerations that can lead to your, what kind of treatment you get. And so just as an example, like neurologic, the degree of cord compression. If you have high-grade cord compression, person comes in, there's a lot of tumor, like the case I showed you a little bit ago, compressing the cord, that person will be treated differently than somebody with low-grade cord compression from epidural disease. It matters if the tumor is radiosensitive, say it is, you go down this path. Is the spine stable? Yes. So it needs to be stable before you keep going, otherwise you want to stabilize it. And can the patient tolerate surgery? You know, obviously that has to be yes if they're going to go to surgery. And so these are your different options: external beam radiation. This is from actually an older paper, 2013, one of the original NOMS papers. But whether it's external beam, SRS, decompression with separation surgery, which you might hear about later, or stabilization, which can also now increasingly involve cement augmentation instead of surgery, or in addition to surgery. So something that I get to do. I get to treat tumors sometimes with ablation and then put cement in with kyphoplasty or vertebroplasty, and that's part of their treatment as well. All right, so we've got a lot of slides left. I'm going to kind of skip through them. John, do you want to be talking while I get to something that maybe we can show here? You have anything to add here while I'm trying to look for something that we can? Well, this is a good case. So you've seen this one before. Because I know we're almost at the end of our time here. We've got like 2 minutes left. So this is a good dramatic case for us to end on, I think. So sagittal T1, sagittal post-contrast fat-saturated image, sagittal T2, CSF is bright. And this is our axial post-contrast. So you can see all of these vertebral bodies are abnormal. T1 hypo-intense, enhancing. There's also enhancement in the epidural space around the spinal cord, prevertebral space. On the sagittal T2, not only, so this was very unusual, there are these loculated collections in the CSF around the cord that are different colors, different signal intensities. Some of this was tumor, some of this was normal CSF, very, very complicated. Metastatic anaplastic angiosarcoma of breast. Horrible case. Circumferential epidural extension of disease. And I don't know, cord compression. It's not being flattened, but it is all around the cord. And that's part of the epidural spinal cord compression scale, which is the third thing you should learn about in addition to NOMS and SINS, which Dr. Rasouli just mentioned. This one, I have no idea how they were treated. I never saw them again. But how would you treat them, Rasouli? Do you have time to tell us? You have 2 minutes. Or do you want to just leave that for another day?
We'll leave it for another day.
I know, that's a hard one, huh? That's really super complicated.
Yeah.
Well,
I guess any questions from the audience? It's a lot. This is a very nuanced subject. There's a lot to know about this, but in general, I think a good starting point for you guys is NOMS and SINS. You start off with those papers that I posted over there, and that gives you a good kind of decision-making framework on how to think about these and approach these tumors systematically.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.